Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Next way we'll be discussing articles is from Kidney International Reports. Providing hemodialysis in unstable areas, an assessment and framework for effective care. Introduction. Providing hemodialysis to patients with kidney failure, KF, in conflict-affected areas poses a significant challenge. Achieving and sustaining reasonable quality hemodialysis operations in such regions necessitates a comprehensive approach. Methods. In the conflict area of Northwest, NW, Syria, a three-phase project was initiated to address the quality of hemodialysis operations. The assessment phase involved the examination of infection prevention and control (IPC) protocols, staff training, medical protocols, individualized hemodialysis prescriptions, and laboratory testing capabilities. The second phase involved activities toward capacity building and implementing an action plan based on feasibility and sustainability. Results. The assessment phase revealed that only 7 of 14 centers had IPC protocols, and 8 centers provided IPC training for their staff. Furthermore, only 7 centers had medical protocols, and 5 used individualized hemodialysis prescriptions. Difficulties in testing for potassium was reported in 7 centers, and the inability to perform hepatitis B and C serologies was reported in 3 centers. Only 2 centers adhered to machine and water treatment system maintenance guidelines, and 4 conducted daily water quality checks. Recommendations were formulated, and an action plan was developed for implementation in the second phase. The plan encompassed enhancements in IPC practices, medical protocols, record-keeping, laboratory testing, and equipment maintenance. Conclusion. This project underscores that hemodialysis services in conflict-affected areas do not meet the standards for quality care. It emphasizes the necessity of implementing a comprehensive framework that engages relevant stakeholders in defining and upholding quality care, a model that should be extended to other protracted conflict-affected regions. Association of EAC and albuminuria with venous thromboembolism. Background. CKD has been implicated as a risk factor of venous thromboembolism, but the evidence is limited to relatively healthy populations. The objective of this study was to discern whether parameters of kidney function and damage are associated with the occurrence of venous thromboembolism after hospitalization. Methods. We conducted a retrospective study including 23,899 and 11,552 adult individuals hospitalized within Geisinger Health System and New York University, NYU, Langone Health from 2004 to 2019 and 2012 to 2022, respectively. A Poisson model was used to evaluate adjusted incidence rates of venous thromboembolism according to EAC and albuminuria categories in each cohort. Cox proportional hazards models were used to analyze associations of EAC and urinary albumin to creatinine ratio, UACR, with venous thromboembolism, and hazard ratios, HRs, were meta-analyzed across cohorts. Results. Both lower EAC and higher Walker were associated with higher risks of venous thromboembolism. In the Geisinger cohort, the incidence of venous thromboembolism after hospital discharge ranged from 10.7, 95% confidence interval, c. 9.2 to 12.6, events per 1,000 person-years in individuals in G1A1, EAC for greater than 90 ml per minute per 1.73 meters 2 and Walker less than 30 mg/g, to 27.7, 95% c. 20.6 to 37.2, events per 1,000 person-years in individuals with G45A3, EAC for less than 30 ml per minute per 1.73 meters 2 and Walker greater than 300 mg/g. A similar pattern was observed in the NYU cohort. Meta-analyses of the two cohorts showed that every 10 milliliters per minute per 1.73 meters 2 reduction in E for below 60 milliliters per minute per 1.73 meters 2 was associated with a 6% higher risk of venous thromboembolism, HR 1.06, 95% C, 1.02 to 1.11, P equals 0.01, and each twofold higher walker was associated with a 5% higher risk of venous thromboembolism, HR 1.05, 95% C, 1.03 to 1.07, P less than 0.001. Conclusions. Both Efer and Walker were independently associated with higher risk of venous thromboembolism after hospitalization. The incidence rate was higher with greater severity of CKD. Next we will be discussing articles is from Clinical Journal of American Society of Nephrology. Strategies to guide preemptive waitlisting and equity in wait time accrual by race/ethnicity. Background. Use of EFR to determine preemptive waitlisting eligibility may contribute to racial/ethnic disparities in access to waitlisting, which can only occur when the EFR falls to less than or equal to 20 milliliters per minute per 1.73 meters 2. Use of an alternative risk-based strategy for waitlisting may reduce these inequities. For example, a kidney failure risk equation, KFRE, estimated 2-year risk of kidney failure, rather than the standard EFR threshold for determining waitlist eligibility. Our objective was to model the amount of preemptive wait time that could be accrued by race and ethnicity, applying two different strategies to determine waitlist eligibility. Methods. Using electronic health record data, linear mixed models were used to compare racial/ethnic differences in preemptive wait time that could be accrued using two strategies, estimating the time between an E for less than or equal to 20 at 5 milliliters per minute per 1.73 meters 2 versus time between a 25% 2-year predicted risk of kidney failure, using the KFRE, which incorporates age, sex, albuminuria, and EFR to provide kidney failure risk estimation, and EFR of 5 milliliters per minute per 1.73 meters 2. Results. Among 1,290 adults with CKD stages 4 to 5, using the chronic kidney disease epidemiology collaboration equation yielded shorter preemptive wait time between an EFR of 20 and 5 milliliters per minute per 1.73 meters 2 in Black, minus 6.8 months, 95% confidence interval, C, minus 11.7 to minus 1.9, Hispanic, minus 10.2 months, minus 15.3 to minus 5.1, and Asian/Pacific Islander, minus 10.3 months, 95% C, minus 15.3 to minus 5.4, patients compared with non-Hispanic white patients. Use of a KFRE threshold to determine wait time yielded smaller differences by race and ethnicity than observed when using a single EFR threshold, with shorter times still noted for Black, minus 2.5 months, 95% C, minus 7.8 to 2.7, Hispanic, minus 4.8 months, 95% C, minus 10.3 to 0.6, and Asian/Pacific Islander, minus 5.4 months, minus 10.7 to minus 0.1, individuals compared with non-Hispanic white individuals, but findings only met statistical significance criteria in Asian/Pacific Islander individuals. When we compared potential wait time availability using a KFRE versus EFR threshold, use of the KFRE yielded more equity in wait time for Black, P equals 0.02, Hispanic, P equals 0.002, and Asian/Pacific Islander, P equals 0.002 patients. Conclusions. Use of a risk-based strategy was associated with greater racial equity in wait time accrual compared with use of a standard single EFR threshold to determine eligibility for preemptive waitlist. Next we will be discussing articles is from Clinical and Translational Gastroenterology. Genetic factors associated with adverse pregnancy outcomes in chronic pancreatitis. Objectives. The effects of genetic factors on pregnancy outcomes in chronic pancreatitis, CP, patients remain unclear. We evaluated the impacts of clinical features and mutations in main CP susceptibility genes, SPINK1, PRSS1, CTRC, CFTR, on pregnancy outcomes in Chinese CP patients. Methods. This was a prospective cohort study with 14-year follow-up. The sample comprised female CP patients with documented pregnancy and known genetic backgrounds. Adverse pregnancy outcomes were compared between patients with and without gene mutations. Univariate and multivariate analyses were performed to determine the impact factors for adverse pregnancy outcomes. Results: totally, 160 female CAMP patients with a pregnancy history were enrolled. 59.4% of patients carried pathogenic mutations in CP susceptibility genes. Adverse pregnancy outcomes occurred in 38 patients, 23.8%. The prevalence of adverse outcomes was significantly higher in those harboring gene mutations than those without, 30.5% versus 13.8%, p equals 0.015. Notably, the rates of preterm delivery, 12.6% versus 3.1%, p equals 0.036, and abortion, 17.9% versus 4.6%, p equals 0.013, were remarkably higher in patients with gene mutations, especially SPINK1 mutations, than those without. In multivariate analyses, both CP susceptibility gene mutations, odds ratio, or 2.52, p equals 0.033, and SPINK1 mutations, or 2.60, p equals 0.037, significantly increased the risk of adverse pregnancy outcomes. Acute pain attack during pregnancy was another risk factor for adverse pregnancy outcomes. Conclusions: pathogenic mutations in CP susceptibility genes, especially SPINK1, were independently related to adverse pregnancy outcomes in CP patients. Significant attention should be paid to pregnant females harboring CP susceptibility gene mutations. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Temporal trends in mortality of critically ill patients with sepsis in the United Kingdom, 1988 to 2019. Rationale: sepsis is a frequent cause of ICU admission and mortality. Objectives: to evaluate temporal trends in the presentation and outcomes of patients admitted to the ICU with sepsis and to assess the contribution of changing case mix to outcomes. Methods: we conducted a retrospective cohort study of patients admitted to 261 ICUs in the United Kingdom during 1988 to 1990 and 1996 to 2019 with non-surgical sepsis. Measurements and main results: a total of 426,812 patients met study inclusion criteria. The patients had a median, interquartile range, age of 66, 53 to 75 years, and 55.6% were male. The most common sites of infection were respiratory, 60.9%, genitourinary, 11.5%, and gastrointestinal, 10.3%. Compared with patients in 1988 to 1990, patients in 2017 to 2019 were older, median age, 66 versus 63 year, were less acutely ill, median acute physiology and chronic health evaluation to acute physiology score, 14 versus 20, and more often had genitourinary sepsis, 13.4% versus 2.0%. Hospital mortality decreased from 54.6%, 95% confidence interval, c. 51.0 to 58.1%, in 1988 to 1990 to 32.4%, 95% c. 32.1 to 32.7%, in 2017 to 2019, with an adjusted odds ratio of 0.64, 95% c. 0.54 to 0.75. The adjusted absolute hospital mortality reduction from 1988 to 1990 to 2017 to 2019 was 8.8%, 95% c. 5.6 to 12.1. Thus, of the observed 22.2 percentage point reduction in hospital mortality, 13.4 percentage points, 60% of total reduction, were explained by case mix changes, whereas 8.8 percentage points, 40% of total reduction, were not explained by measured factors and may be a result of improvements in ICU management. Conclusions: over a 30-year period, mortality for ICU admissions with sepsis decreased substantially. Although changes in case mix accounted for the majority of observed mortality reduction, there was an 8.8 percentage point reduction in mortality not explained by case mix. External validation of the BISS score in Canadian patients with nontuberculous mycobacterial pulmonary disease. Background: the clinical course of nontuberculous mycobacterial pulmonary disease, NTMPD, can be variable and difficult to predict. Recently, the BISS score was developed as a tool to predict all-cause mortality in patients with NTMPD. This score is calculated based on 5 patient characteristics: BMI, age, cavity, erythrocyte sedimentation rate, and sex, and higher scores portend worse prognosis. Although the BISS score has been validated in a cohort of South Korean patients, it has not yet been validated in other settings or ethnic groups. Research question: how well does the BISS mortality score perform in a cohort of Canadian patients with NTMPD? Study design and methods. We performed a single-center retrospective chart review. Patients who were seen between July 2003 and June 2021 were eligible for inclusion if they met guideline-based diagnostic criteria for NTMPD and were excluded if any component of the BISS score was missing. To assess the model's discriminatory performance, we compared Kaplan-Meier curves between risk groups and calculated Harrell's C index. To assess calibration, we used a graphical calibration curve. Results: the cohort included 435 patients with a median follow-up of 5.8 years. The median age was 64 years and 74% were female. Based on the BISS scores, patients were classified into 3 risk groups: low, moderate, or high. Survival curves showed clear separation of the risk groups. Harrell's C index was 0.733 in the study cohort, indicating moderate to good discriminatory performance, although this was lower than the value reported in the derivation cohort, 0.812. The graphical calibration curve showed a tendency of the BISS model to underpredict mortality. Interpretation: the BISS model was evaluated in a multicultural cohort of Canadian patients and demonstrated good discriminatory performance but suboptimal calibration, which may be due to population differences, the use of dichotomized variables in model construction, or both. Next, we will be discussing articles from CHEST. Legionnaire's disease in solid organ transplant recipients. Background: Legionnaire's disease, LD, is a rare, life-threatening opportunistic bacterial infection that poses a significant risk to patients with impaired cell-mediated immunity such as solid organ transplant recipients. However, the epidemiologic features, clinical presentation, and outcomes of LD in this population are poorly described. Research question: what are the clinical manifestations, radiologic presentation, risk factors for severity, treatment, and outcome of LD in solid organ transplant recipients? Study design and methods. In this 10-year multi-center retrospective cohort study in France, where LD notification is mandatory, patients were identified by hospital discharge databases. Diagnosis of LD relied on positive culture findings from any respiratory sample, positive urinary antigen test, UAT, results, positive specific serologic findings, or a combination thereof. Severe LD was defined as admission to the ICU. Results: 101 patients from 51 transplantation centers were eligible. 64 patients, 63.4%, were kidney transplant recipients. Median time between transplantation and LD was 5.6 years, interquartile range, 1.5 to 12 years. WAT results were positive in 92% of patients, 89-97. Among 31 patients with positive culture findings in respiratory samples, Legionella pneumophila serogroup 1 was identified in 90%. Chest CT imaging showed alveolar consolidation in 98% of patients, 54 of 57, ground glass opacity in 63% of patients, 36 of 57, macronodules in 21% of patients, 12 of 57, and cavitation in 8.8% of patients, 5 of 57. 57 patients, 56%, were hospitalized in the ICU. In multivariate analysis, severe LD was associated with negative WAT findings at presentation, p equals 0.047, lymphopenia, p equals 0.014, respiratory symptoms, p equals 0.010, and pleural effusion, p equals 0.039. The 30-day and 12-month mortality rates were 8%, 8 of 101, and 20%, 19 of 97, respectively. In multivariate analysis, diabetes mellitus was the only factor associated with 12-month mortality, hazard ratio, 3.2, 95% or 1.19 to 8.64, p equals 0.022. Interpretation: LD is a late and severe complication occurring in solid organ transplant recipients that may present as pulmonary nodules on which diabetes impacts its long-term prognosis. Next, we will be discussing articles from Neurology. Cinpanemab in early Parkinson disease, evaluation of biomarker results from the Phase 2 SPARK clinical trial. Background and objectives. Sensitive, reliable, and scalable biomarkers are needed to accelerate the development of therapies for Parkinson disease, PD. In this study, we evaluate the biomarkers of early PD diagnosis, disease progression, and treatment effect collected in the SPARK. Methods. Cinpanemab is a human-derived monoclonal antibody binding preferentially to aggregated forms of extracellular alpha-synuclein. SPARK was a randomized, double-blind, placebo-controlled, Phase 2 multicenter trial evaluating 3 cinpanemab doses administered intravenously every 4 weeks for 52 weeks with an active treatment dose blind extension period for up to 112 weeks. SPARK enrolled 357 participants diagnosed with PD within 3 years, aged 40 to 80 years, less than or equal to 2.5 on the modified Hoehn-Yahr scale, and with evidence of striatal dopaminergic deficit. The primary outcome was change from baseline in the Movement Disorder Society-sponsored revision of the Unified Parkinson's Disease Rating Scale total score. Secondary and exploratory biomarker outcomes evaluated change from baseline at week 52 relative to placebo. Dopamine transporter SPECT and MRI were used to quantify changes in the nigrostriatal dopamine pathway and regional atrophy. CSF and plasma samples were used to assess change in total alpha-synuclein levels, alpha-synuclein seeding, and neurofilament light chain levels. SPARK was conducted from January 2018 to April 2021 and terminated due to lack of efficacy. Results. Approximately 3.8%, 15,398, of SPECT image participants did not have evidence of dopaminergic deficit and were screen failed. Binary classification of alpha-synuclein seeding designated 93%, 110-118 of the enrolled CSF subgroup as positive for alpha-synuclein seeds at baseline. Clinical disease progression was observed, with no statistically significant difference in cinpanemab groups compared with that in placebo. 99% of participants with positive alpha-synuclein seeding remained positive through week 52. No statistically significant changes from baseline were observed between treatment groups and placebo across biomarker measures. Broadly, there was minimal annual change with high interindividual variability across biomarkers, with striatal binding ratios of the ipsilateral putamen showing the greatest mean change/SD over time. Discussion. Biomarker results indicated enrollment of the intended population with early PD, but there was no significant correlation with disease progression or clear evidence of a cinpanemab treatment effect on biomarker measures. Suitable biomarkers for evaluating disease severity and progression in early PD trials are still needed. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Predictive risk score for post-parathyroidectomy Hungry bone syndrome in patients with secondary hyperparathyroidism. Purpose. Secondary hyperparathyroidism, SHPT, frequently affects patients with end-stage renal disease. Hungry bone syndrome, HBS, is a common complication among patients who undergo parathyroidectomy for SHPT and may cause prolonged hospitalization or require intensive care. The objective of this study is to develop a scoring system to stratify patients according to their risk of developing HBS. Methods. A retrospective cohort study was performed using the U.S. Renal Data System, 2010 to 2021. Univariable and multivariable logistic regression models were developed and weighted beta coefficients from the multivariable model were used to construct a risk score for the development of HBS. Positive and negative predictive values were assessed. Results. Of 17,074 patients who underwent parathyroidectomy for SHPT, 19.4% developed HBS. Intensive care unit admission was more common in patients who developed HBS, 33.5% versus 24.6%, p less than 0.001. On multivariable logistic regression analysis, younger age, renal osteodystrophy, longer duration of dialysis, longer duration of kidney transplant, and higher Elixhauser score were significantly associated with HBS. A risk score based on these clinical factors was developed, with a total of 6 possible points. Rates of HBS ranged from 8% in patients with 0 points to 44% in patients with 6 points. The risk score had a poor positive predictive value, 20.3%, but excellent negative predictive value, 89.3%, for HBS. Conclusion: we developed a weighted risk score that effectively stratifies patients by risk for developing HBS after parathyroidectomy. This tool can be used to counsel patients and to identify patients who may not require postoperative hospitalization. Next, we will be discussing articles from journals of the American College of Cardiology. Lipoprotein A and major adverse cardiovascular events in patients with or without baseline atherosclerotic cardiovascular disease. Background: lipoprotein A, LPA, is associated with an increased risk of atherosclerotic cardiovascular disease, ASCAD. However, whether the optimal LPA threshold for risk assessment should differ based on baseline ASCAD status is unknown. Objectives: the purpose of this study was to assess the association between LPA and major adverse cardiovascular events, MACE, among patients with and without baseline ASCAD. Methods: we studied a retrospective cohort of patients with LPA measured at 2 medical centers in Boston, Massachusetts, from 2000 to 2019. To assess the association of LPA with incident MACE, non-fatal myocardial infarction, MI, non-fatal stroke, coronary revascularization, or cardiovascular mortality, LPA percentile groups were generated with the reference group set at the 1st to 50th LPA percentiles. Cox proportional hazards modeling was used to assess the association of LPA percentile group with MACE. Results: overall, 16,419 individuals were analyzed with a median follow-up of 11.9 years. Among the 10,181, 62%, patients with baseline ASCAD, individuals in the 71st to 90th percentile group had a 21% increased hazard of MACE, adjusted HR, 1.21, p less than 0.001, which was similar to that of individuals in the 91st to 100th group, adjusted HR, 1.26, p less than 0.001. Among the 6,238 individuals without established ASCAD, there was a continuously higher hazard of MACE with increasing LPA, and individuals in the 91st to 100th LPA percentile group had the highest relative risk with an adjusted HR of 1.93, p less than 0.001. Conclusions: in a large, contemporary U.S. cohort, elevated LPA is independently associated with long-term MACE among individuals with and without baseline ASCAD. Our results suggest that the threshold for risk assessment may be different in primary versus secondary prevention cohorts. Next, we will be discussing articles. American College of Cardiology. Arm and ankle BP indices, PAD, and mortality. Study questions. What is the relationship between various arm and ankle blood pressure, BP, indices with regard to clinically significant peripheral artery disease, PAD, and mortality? Methods. The authors used data from 3 large prospective clinical trials to compare baseline BP indices of the arm systolic BP, SBP, arm diastolic BP, DBP, pulse pressure, arm SBP minus DBP, ankle SBP, ankle brachial index, ABI, ankle SBP divided by arm SBP, and ankle pulse pressure difference, ankle SBP minus arm pulse pressure. Analyses were based on quartiles for each BP index. The 3 outcomes of interest were the first incidence of peripheral revascularization or amputation for PAD, all-cause death, and the composite of PAD intervention or death. Cox proportional hazards models were generated for each predictor with discrimination assessed using C statistics and reclassification indices. These models were adjusted for several factors known to impact PAD and mortality, including diabetes, hypertension, prior cardiovascular disease, and smoking. Results. The study included 40,747 participants without baseline PAD who were mean age 65.6 years, 68.3% men, and 50.2% with diabetes. These participants were recruited from 53 countries. Among the cohort, 2.6% developed PAD that required an intervention and 12.2% died during 5 years of follow-up. Incident PAD requiring an intervention rose with all arm BP indices and fell with all ankle BP indices. The strongest relationship to incident PAD was noted for ankle BP indices. Compared with the highest quartile of ankle SBP, each lower quartile was associated with an increased hazard for incident PAD, adjusted hazard ratio, 1.64, 95% confidence interval, 1.31 to 2.04, 2.59, 2.10 to 3.20, and 4.23, 3.44 to 5.21, respectively. Incident PAD was also strongly associated with decreasing ABI and ankle pulse pressure difference. Similar patterns were also seen for the association between various BP indices and all-cause mortality. The ankle BP indices provided the highest level of discrimination. See statistics and reclassification indices to predict future PAD requiring an intervention when controlling for established risk factors. Conclusions. The authors conclude that ankle BP indices, including ankle SBP and the ankle pulse pressure difference, best predict PAD requiring intervention and all-cause mortality. Next, we will be discussing articles from Circulation. Concomitant left atrial appendage occlusion and transcatheter aortic valve replacement among patients with atrial fibrillation. Background. Atrial fibrillation, AF, is common in patients undergoing transcatheter aortic valve replacement, TAVR, and is associated with increased risk of bleeding and stroke. While left atrial appendage occlusion, LAAO, is approved as an alternative to anticoagulants for stroke prevention in patients with AF, placement of these devices in patients with severe aortic stenosis, or when performed at the same time as TAVR, has not been extensively studied. Methods. Watch TAVR, Watchman for patients with AF undergoing TAVR, was a multicenter, randomized trial evaluating the safety and effectiveness of concomitant TAVR and LAO with Watchman in AF patients. Patients were randomized 1:1 to TAVR plus LAO or TAVR plus medical therapy. Watchman patients received anticoagulation for 45 days followed by dual antiplatelet therapy until 6 months. Anticoagulation was per treating physician preference for patients randomized to TAVR plus medical therapy. The primary non-inferiority endpoint was all-cause mortality, stroke, and major bleeding at 2 years between the two strategies. Results. The study enrolled 349 patients, 177 TAVR plus LAO and 172 TAVR plus medical therapy, between December 2017 and November 2020 at 34 U.S. centers. The mean age of patients was 81 years, and the mean scores for CHOD2 DS2 VOSC and has bled, hypertension, abnormal renal/liver function, stroke, bleeding history or predisposition, label INR, elderly, drugs/alcohol concomitantly, were 4.9 and 3.0 respectively. At baseline, 85.4% of patients were taking anticoagulants and 71.3% patients were on antiplatelet therapy. The cohorts were well balanced for baseline characteristics. The incremental LAO procedure time was 38 minutes, and the median contrast volume used for combined procedures was 119 ml versus 70 ml with TAVR alone. At the 24-month follow-up, 82.5% compared with 50.8% of patients were on any antiplatelet therapy, and 13.9% compared with 66.7% of patients were on any anticoagulation therapy in TAVR plus LAO compared with TAVR plus medical therapy group, respectively. For the composite primary endpoint, TAVR plus LAO was non-inferior to TAVR plus medical therapy, 22.7 versus 27.3 events per 100 patient years for TAVR plus LAO and TAVR plus medical therapy, respectively. Hazard ratio 0.86, 95% C, 0.60 to 1.22, non-inferiority less than 0.001. Conclusions. Concomitant Watchman Lao and TAVR is non-inferior to TAVR with medical therapy in severe aortic stenosis patients with AF. The increased complexity and risks of the combined procedure should be considered when concomitant Lao is viewed as an alternative to medical therapy for patients with AF undergoing TAVR. Next, we will be discussing articles from Arthritis and Rheumatology. Methotrexate safety and efficacy in combination therapies in patients with early rheumatoid arthritis, a post-hoc analysis of a randomized controlled trial. Objective: we investigated methotrexate safety and the influence of dose on efficacy outcomes in combination with 3 different biologic treatments and with active conventional treatment, ACT, in early rheumatoid arthritis, RA. Methods: this post-hoc analysis included 812 treatment-naive patients with early RA who were randomized, 1:1:1:1, in the North Star trial to receive methotrexate in combination with ACT, certolizumab pegol, abatacept, or tocilizumab. Methotrexate safety, doses, and dose effects on Clinical Disease Activity Index, CDAI, remission were assessed after 24 weeks of treatment. Results: compared with ACT, the prevalence of methotrexate-associated side effects was higher when methotrexate was combined with tocilizumab. Hazard ratio, HR, 1.48, 95% confidence interval, C, 1.20 to 1.84, but not with certolizumab pegol, HR 0.99, 95% C 0.79 to 1.23, or with abatacept, HR 0.93, 95% C 0.75 to 1.16. With ACT as the reference, the methotrexate dose was significantly lower when used in combination with tocilizumab, beta-4.65, 95% C -5.83 to -3.46, P less than 0.001, or abatacept, beta-1.15, 95% C -2.27 to -0.03, P equals 0.04, and it was numerically lower in combination with certolizumab pegol, beta-1.07, 95% C -2.21 to 0.07, P equals 0.07. Methotrexate dose reductions were not associated with decreased C-day remission rates within any of the treatment combinations. Conclusion: methotrexate was generally well tolerated in combination therapies, but adverse events were a limiting factor in receiving the target dose of 25 mg/WK, and these were more frequent in combination with tocilizumab versus ACT. On the other hand, methotrexate dose reductions were not associated with decreased C-day remission rates within any of the 4 treatment combinations at 24 weeks. Next, we will be discussing articles from Journal of Clinical Rheumatology. Interleukin-6 levels and disease activity in Takayasu arteritis, a systematic review with meta-analysis. Background: various studies have suggested interleukin-6, IL-6, as a potential biomarker for detecting disease activity in Takayasu arteritis. Methods: a systematic review and meta-analysis was performed to assess differences in IL-6 levels in patients with active, ATA, and inactive Takayasu arteritis, ETA, as well as healthy controls, HCs, using validated activity scores. Study quality and the risk of bias were assessed using STROBE, strengthening the reporting of observational studies in epidemiology, and the Newcastle, Ottawa, and Joanna Briggs checklist, respectively. For the meta-analysis, we pooled the raw mean IL-6 levels in each group and then estimated and pooled the crude mean differences between the groups. We applied a random effects model in all analyses. Results: of the 93 eligible articles, 10 were included after removing duplicates and studies that met the exclusion criteria. Overall, 1825 patients with a mean age ranging from 24 to 40.6 years were included. The pooled levels of IL-6 increased depending on disease activity as follows: HCs, 3.08, 95% confidence interval, C, 0.88 to 5.28, ETA, 7.21, 3.61 to 10.82, and ATA, 22.67, 12.44 to 32.91, pg per milliliter. Patients with ATA had higher IL-6 levels than HCs, 21.52, 95% C, minus 0.43 to 43.47, and those with EDA, 16.69, 95% C, 5.32 to 28.06, whereas IL-6 levels were not different between HCs and patients with EDA, 3.62, 95% C, minus 13.18 to 20.42. Conclusions. Interleukin-6 levels are significantly increased in patients with ADA compared with those with EDA and HCs, but not in patients with EDA compared with HCs. More studies are needed to establish the IL-6 cutoff value for assessing disease activity. Next, we will be discussing articles from Clinical Infectious Diseases. Persistence of detectable pathogens by culture-independent systems, T2 magnetic resonance, in patients with bloodstream infection, prognostic role and possible clinical implications. Background. Persistent Staphylococcus aureus bacteremia is associated with metastatic infection and adverse outcomes, whereas gram-negative bacteremia is normally transient and shorter course therapy is increasingly advocated for affected patients. Whether the prolonged detection of pathogen DNA in blood by culture-independent systems could have prognostic value and guide management decisions is unknown. Methods. We performed a multi-center, prospective, observational study on 102 patients with bloodstream infection, BSI, to compare time to bloodstream clearance according to T2 magnetic resonance and blood cultures over a 4-day follow-up. We also explored the association between duration of detectable pathogens according to T2 magnetic resonance D-anemia, Mr. D-anemia, and clinical outcomes. Results. Time to bloodstream clearance according to T2 magnetic resonance was significantly longer than blood culture clearance, HR, 0.54, 95% C, 0.39. 75, and did not differ according to the causative pathogen, P equals 0.5. Each additional day of Mr. D anemia increased the odds of persistent infection, defined as metastatic infection or delayed source control, both in the overall population, or 1.98, 95% C, 1.45 to 2.70, and in S. aureus, or 1.92, 95% C, 1.12 to 3.29, and gram-negative bacteremia, or 2.21, 95% C, 1.35 to 3.60. Mr. D anemia duration was also associated with no improvement in sequential organ failure assessment score at day 7 from infection onset, or 1.76, 95% C, 1.21 to 2.56. Conclusions. T2 magnetic resonance may help diagnose BSI in patients on antimicrobials with negative blood cultures, as well as to identify patients with metastatic infection, source control failure, or adverse short-term outcome. Future studies may inform its usefulness within the setting of antimicrobial stewardship programs. Next, we will be discussing articles from Clinical Liver Disease. Screening for hepatitis C as part of an opioid stewardship quality improvement initiative, identifying infected patients and analyzing linkage to care. Screening patients with opioid use disorder, OUD, for HCV can potentially decrease morbidity and mortality if HCV-infected individuals are linked to care. We describe a quality improvement initiative focused on patients with OUD, incorporating an electronic health record decision support tool for HCV screening across multiple healthcare venues, and examining the linkage to HCV care. Of 5,829 patients with OUD, 4,631 were tested for HCV, 79.4%, compared to a baseline of 8%, and 1,614, 27.7%, tested positive. 230 patients had died at the study onset. Patients tested in the acute care and emergency department settings were more likely to test positive than those in the ambulatory setting, or equals 2.21 and 2.49, p less than 0.001. Before patient outreach, 279, 18.2%, HCV-positive patients were linked to care. After patient outreach, 326, 23.0%, total patients were linked to care. Secondary endpoints included mortality and the number of patients who were HCV-positive who achieved a cure. The mortality rate in patients who were HCV-positive, 12.2%, was higher than that in patients who were HCV negative, 7.4%, or equals 1.72, p less than 0.001, or untested patients, 6.2%, or equals 2.10, p less than 0.001. Of the 326 with successful linkage to care, 113, 34.7%, had a documented cure. An additional 55, 16.9%, patients had a possible cure, defined as direct-acting antiviral ordered but no follow-up documented, known treatment in the absence of documented sustained viral response lab draw, or documentation of cure noted in outside medical records but unavailable laboratory results. A strategy utilizing electronic health record decision support tools for testing patients with UD for HCV was highly effective. However, linking patients with HCV to care was less successful. Snare tip soft coagulation versus argon plasma coagulation versus no margin treatment after large non-punctulated colorectal polyp resection, a randomized trial. Background and aims. Thermal treatment of the defect margin after endoscopic mucosal resection, EMR, of large non-punctulated colorectal lesions reduces the recurrence rate. Both snare tip soft coagulation, STSC, and argon plasma coagulation, APC, have been used for thermal margin treatment, but there are few data directly comparing STSC with APC for this indication. Methods. We performed a randomized 3-arm trial in 9 U.S. centers comparing STSC with APC with no margin treatment, control, of defects after EMR of colorectal non-punctulated lesions greater than or equal to 15 mm. The primary endpoint was the presence of residual lesion at first follow-up. Results. There were 384 patients and 414 lesions randomized, and 308 patients, 80.2%, with 328 lesions completed greater than or equal to 1 follow-up. The proportion of lesions with residual polyp at first follow-up was 4.6% with STSC, 9.3% with APC, and 21.4% with control subjects, no margin treatment. The odds of residual polyp at first follow-up were lower for STSC and APC when compared with control subjects, p equals 0.001 and p equals 0.01 respectively. The difference in odds was not significant between STSC and APC. STSC took less time to apply than APC, median, 3.35 versus 4.08 minutes, p equals 0.019. Adverse event rates were low, with no difference between arms. Conclusions. In a randomized trial, STSC and APC were each superior to no thermal margin treatment after EMR. STSC was faster to apply than APC. Because STSC also results in lower cost and plastic waste than APC, APC requires an additional device. Our study supports STSC as the preferred thermal margin treatment after colorectal EMR. Next, we will be discussing articles from Clinical Gastroenterology. The severity of reduced esophageal distensibility parallels eosinophilic esophagitis disease duration. Background and aims. Chronic inflammation of eosinophilic esophagitis, O, results in progressive, fibrostenotic remodeling of the esophageal wall. This study aimed to demonstrate objective changes in esophageal distensibility relative to duration of O disease using a functional lumen imaging probe, FLIP. Methods. Adult patients with O who completed a 16 cm FLIP protocol during endoscopy were evaluated in a cross-sectional study. FLIP analysis focused on distensibility plateau, DP, of the esophageal body. The time from onset of symptoms to time of endoscopy with FLIP was assessed, as was time from symptom onset to O diagnosis, E, diagnostic delay. Results. A total of 171 patients, mean age 38 plus or minus 12 years, 31% female, were included. The median symptom duration was 8, interquartile range, 3 to 15 years, and diagnostic delay was 4, interquartile range, 1 to 12 years. At the time of endoscopy with FLIP, there were 54 patients, 39%, in histologic remission, less than 15 eosinophils per high-power field, EOS/HPF. Symptom duration and diagnostic delay were negatively correlated with DP, ρ equals minus 0.326, N minus 0.309, p-values less than 0.001. Abnormal esophageal distensibility, DP less than or equal to 17 mm, was more prevalent with increased duration of symptoms, p less than 0.004, 23% at less than 5 years to 64% at greater than or equal to 25 years. When stratifying the cohort based on mucosal eosinophil density, patients with greater than or equal to 15 EO/HPF had significantly lower DP with greater symptom duration, p equals 0.004, while there was not a significant difference among patients with less than 15 EO/HPF, p equals 0.060. Conclusions. Esophageal distensibility objectively measured with FLIP was reduced in O patients with greater symptom duration and diagnostic delay. This supports that O is a progressive, fibrostenotic disease and that FLIP may be a useful tool to monitor disease progression in O. Next we will be discussing articles from Journal of Hepatology. Adipose tissue macrophage dysfunction is associated with a breach of vascular integrity in NASH. Background and aims. In non-alcoholic fatty liver disease, NAFLD, monocytes infiltrate visceral adipose tissue promoting local and hepatic inflammation. However, it remains unclear what drives inflammation and how the immune landscape in adipose tissue differs across the NAFLD severity spectrum. We aim to assess adipose tissue macrophage, ATM, heterogeneity in a NAFLD cohort. Methods. Visceral adipose tissue macrophages from lean and obese patients, stratified by NAFLD phenotypes, underwent single-cell RNA sequencing. Adipose tissue vascular integrity and breaching was assessed on a protein level via immunohistochemistry and immunofluorescence to determine targets of interest. Results. We discovered multiple ATM populations, including resident vasculature-associated macrophages, RESFAMs, and distinct metabolically active macrophages, MACs. Using trajectory analysis, we show that RESFAMs and MACs are replenished by a common transitional macrophage, TransMac, subtype NAT. During NASH, MACs are not effectively replenished by TransMac precursors. We postulate an accessory role for MACs and RESFAMs in protecting the adipose tissue vascular barrier, since they both interact with endothelial cells and localize around the vasculature. However, across the NAFLD severity spectrum, alterations occur in these subsets that parallel an adipose tissue vasculature breach characterized by albumin extravasation into the perivascular tissue. Conclusions. NAFLD-related macrophage dysfunction coincides with a loss of adipose tissue vascular integrity, providing a plausible mechanism by which tissue inflammation is perpetuated in adipose tissue and downstream in the Next we will be discussing articles from Journal of Clinical Oncology. Long-term results of the dasatinib blinatumomab protocol for adult Philadelphia positive all. We report the long-term results of the frontline trial with dasatinib and blinatumomab in induction/consolidation, Gimamolol 2116, D-ALBA, for adult Philadelphia positive all, PH plus all, which enrolled 63 patients of all ages. At a median follow-up of 53 months, disease-free survival, overall survival, and event-free survival are 75.8%, 80.7%, and 74.6%, respectively. No events have occurred among early molecular responders. A significantly worse outcome was recorded for IX1+ patients. 29 patients, 93.1% being in molecular response, complete molecular response or positive non-quantifiable, after dasatinib/blinatumomab, never received chemotherapy/transplant and continued with a tyrosine kinase inhibitor only. 28 patients remain in long-term complete hematologic response, CHR. An allogeneic transplant was carried out in first CHR mainly in patients with persistent minimal residual disease. 83.3% of patients are in continuous CHR. The transplant-related mortality was 12.5% for patients transplanted in first CHR and 13.7% overall. 9 relapses and 6 deaths have occurred. ABL1 mutations were found in 7 cases. The final analysis of the D-ALBA study shows that a chemotherapy-free induction/consolidation regimen on the basis of a targeted strategy, dasatinib and immunotherapy, Blinatumomab is effective in inducing durable long-term hematologic and molecular responses in adult PH plus all, paving the way for a new era in the management of these patients. Next, we will be discussing articles from Lancet. The performance of 11 fingertip pulse oximeters during hypoxemia in healthy human participants with varied, quantified skin pigment. Background. Fingertip pulse oximeters are widely available, inexpensive, and commonly used to make clinical decisions in many settings. Device performance is largely unregulated and poorly characterized, especially in people with dark skin pigmentation. Methods. 11 popular fingertip pulse oximeters were evaluated using the U.S. Food and Drug Administration, FDA, guidance, 2013, and International Organization for Standardization Standards, I.O., 2017, in 34 healthy humans with diverse skin pigmentation utilizing a controlled desaturation study with arterial oxygen saturation, SO2, plateaus between 70% and 100%. Skin pigmentation was assessed subjectively using a perceived Fitzpatrick scale, PFP, and objectively using the individual typology angle, ITA, via spectrophotometry at 9 anatomical sites. Findings: 5 of 11 devices had a root mean square error, ARMS, greater than 3%, falling outside the acceptable FDA performance range. 9 devices demonstrated worse performance in participants in the darkest skin pigmentation category compared with those in the lightest category. A commonly used subjective skin color scale frequently miscategorized participants as being darkly pigmented when compared to objective quantification of skin pigment by ETA. Interpretation. Fingertip pulse oximeters have variable performance, frequently not meeting regulatory requirements for clinical use, and occasionally contradicting claims made by manufacturers. Most devices showed a trend toward worse performance in participants with darker skin pigment. Regulatory standards do not adequately account for the impact of skin pigmentation on device performance. We recommend that the PFP and other non-standardized subjective skin color scales should no longer be used for defining diversity of skin pigmentation. Reliable methods for characterizing skin pigmentation to improve diversity and equitable performance of pulse oximeters are needed. Next, we will be discussing articles from British Medical Journal: Comparison of Prior Authorization Across Insurers, Cross-Sectional Evidence from Medicare Advantage. Objective to measure and compare the scope of U.S. insurers' policies for prior authorization, PA, a process by which insurers assess the necessity of planned medical care, and to quantify differences in PA across insurers, physician specialties, and clinical service categories. Design cross-sectional analysis. Setting PA policies for 5 insurers serving most of the beneficiaries covered by privately administered Medicare Advantage in the U.S., 2021, as applied to utilization patterns observed in Medicare Part B. Participants 3,540,086 beneficiaries in traditional Medicare Part B. Main outcome measures proportions of government-administered traditional Medicare Part B spending and utilization that would have required PA according to Medicare Advantage insurer rules. Results: the insurers required PA for 944 to 2,971 of the 14,130 clinical services, median 1,899, weighted mean 1,429, constituting 17% to 33% of Part B spending, median 28%, weighted mean 23%, and 9% to 41% of Part B utilization, median 22%, weighted mean 18%. 40% of spending, $57 billion, £45 billion, €53 billion, and 48% of service utilization would have required PA by at least one insurer, 12% of spending and 6% of utilization would have required PA by all insurers. 93% of Part B medication spending, or 74% of medication use, would have required PA by at least one Medicare Advantage insurer. For all Medicare Advantage insurers, hematology and oncology drugs represented the largest proportion of PA spending, ranged 27 to 34%, median 33%, weighted mean 30%. PA rates varied widely across specialties. Conclusion: PA policies varied substantially across private insurers in the U.S. Despite limited consensus, all insurers required PA extensively, particularly for physician-administered medications. These findings indicate substantial differences in coverage policies between government-administered and privately administered Medicare. The results may inform ongoing efforts to focus PA more effectively on low-value services and reduce administrative burdens for clinicians and patients. Next, we will be discussing articles from Nature Medicine. Sex-specific genetic architecture of blood pressure. The genetic and genomic basis of sex differences in blood pressure, BP, traits remain unstudied at scale. Here, we conducted sex-stratified and combined sex genome-wide association studies of BP traits using the UK Biobank resource, identifying 1,346 previously reported and 29 new BP trait-associated loci. Among associated loci, 412 were female-specific, male less than or equal to 5 × 10⁻⁸, male greater than 5 × 10⁻⁸, and 142 were male-specific, male less than or equal to 5 × 10⁻⁸, male greater than 5 × 10⁻⁸. These sex-specific loci were enriched for hormone-related transcription factors, in particular, estrogen receptor 1. Analyses of gene by sex interactions and sexually dimorphic effects identified 4 genomic regions, showing female-specific associations with diastolic BP or pulse pressure, including the chromosome 13q34 col4A1/col4A2 locus. Notably, female-specific pulse pressure-associated loci exhibited enriched acetylated histone H3-Lys27 modifications in arterial tissues and a female-specific association with fibromuscular dysplasia, a female-biased vascular disease. Colocalization signals included CHR13q34, col4A1/col4A2, CHR9p21, CDKN2BAS1 and CHR4q32.1, MAP9 regions. Sex-specific and sex-biased polygenic associations of BP traits were associated with multiple cardiovascular traits. These findings suggest potentially clinically significant and BP sex-specific pleiotropic effects on cardiovascular diseases. Next, we will be discussing articles from Annals of Internal Medicine. Healthcare contact days among older adults in traditional Medicare. Background: days spent obtaining health care outside the home can represent not only access to needed care but also substantial time, effort, and cost, especially for older adults and their care partners. Yet, these healthcare contact days have not been characterized. Objective: to assess composition of, variation and patterns in, and factors associated with contact days among older adults. Design: cross-sectional study. Setting: nationally representative 2019 Medicare Current Beneficiary Survey data linked to claims. Participants: community-dwelling adults aged 65 years and older in traditional Medicare. Measurements: ambulatory contact days, days with a primary care or specialty care office visit, test, imaging, procedure, or treatment, and total contact days, ambulatory days plus institutional days in a hospital, emergency department, skilled nursing facility, or hospice facility, multivariable mixed effects Poisson regression to identify patient factors associated with contact days. Results: in weighted results, 6,619 older adults, weighted, 29,694,084, had means of 17.3 ambulatory contact days, SD, 22.1, and 20.7 total contact days, SD, 27.5, in the year. 11.1% had 50 or more total contact days. Older adults spent most contact days on ambulatory care, including primary care visits, mean, SD, 3.5, 5.0, specialty care visits, 5.7, 9.6, tests, 5.3, 7.2, imaging, 2.6, 3.9, procedures, 2.5, 6.4, and treatments, 5.7, 13.3. Half of the test and imaging days were not on the same days as office visits, 48.6% and 50.1%, respectively. Factors associated with more ambulatory contact days included younger age, female sex, white race, non-Hispanic ethnicity, higher income, higher educational attainment, urban residence, more chronic conditions, and care-seeking behaviors, for example, go to the doctor, as soon as, I feel bad. Limitation. Study population limited to those in traditional Medicare. Conclusion. On average, older adults spend 3 weeks in the year getting care outside the home. These contact days were mostly ambulatory and varied widely not only by number of chronic conditions but also by socio-demographic factors, geography, and care-seeking behaviors. These results show factors beyond clinical need that may drive overuse and underuse of contact days and opportunities to optimize this person-centered measure to reduce patient burdens, for example, via care coordination. Next, we will be discussing articles from Journal of American Medical Association. Time to treatment with intravenous thrombolysis before thrombectomy and functional outcomes in acute ischemic stroke, a meta-analysis. Objective to determine whether the benefit associated with IVT plus thrombectomy versus thrombectomy alone decreases with treatment time from symptom onset. Design, setting, and participants. Individual participant data meta-analysis from 6 randomized clinical trials comparing IVT plus thrombectomy versus thrombectomy alone. Enrollment was between January 2017 and July 2021, 190 sites in 15 countries. All participants were eligible for IVT and thrombectomy and presented directly at thrombectomy-capable stroke centers, N equals 2,334. Exposure interval from stroke symptom onset to expected administration of IVT and treatment with IVT plus thrombectomy versus thrombectomy alone. Main outcomes and measures. The primary outcome analysis tested whether the association between the allocated treatment, IVT plus thrombectomy versus thrombectomy alone, and visibility at 90 days, 7-level modified Rankin scale, misses, score range, 0, no symptoms, to 6, death. Minimal clinically important difference for the rates of misses scores of 0 to 2, 1.3%, varied with times from symptom onset to expected administration of IVT. Results in 2,313 participants, 1,160 in IVT plus thrombectomy group versus 1,153 in thrombectomy alone group, median age, 71, IQR, 62 to 78, years, 44.3% were female. The median time from symptom onset to expected administration of IVT was 2 hours 28 minutes, IQR, 1 hour 46 minutes to 3 hours 17 minutes. There was a statistically significant interaction between the time from symptom onset to expected administration of IVT and the association of allocated treatment with functional outcomes, ratio of adjusted common odds ratio or per 1 hour delay, 0.84, 95% C, 0.72 to 0.97, p equals 0.02 for interaction. The benefit of IVT plus thrombectomy decreased with longer times from symptom onset to expected administration of IVT, adjusted common or for a one-step misses score shift toward improvement, 1.49, 95% C, 1.13 to 1.96, at 1 hour, 1.25, 95% C, 1.04 to 1.49, at 2 hours, and 1.04, 95% C, 0.88 to 1.23, at 3 hours. For a misses score of 0, 1, or 2, the predicted absolute risk difference was 9%, 95% C, 3% to 16%, at 1 hour, 5%, 95% C, 1% to 9%, at 2 hours, and 1%, 95% C, minus 3% to 5%, at 3 hours. After 2 hours 20 minutes, the benefit associated with IVT plus thrombectomy was not statistically significant and the point estimate crossed the null association at 3 hours 14 minutes. Conclusions and relevance in patients presenting at thrombectomy-capable stroke centers. The benefit associated with IVT plus thrombectomy versus thrombectomy alone was time-dependent, and statistically significant only if the time from symptom onset to expected administration of IVT was short. Benralizumab versus Mepolizumab for eosinophilic granulomatosis with polyangiitis. Background: Eosinophilic granulomatosis with polyangiitis, EGPA, is a vasculitis characterized by eosinophilic inflammation. Benralizumab, a monoclonal antibody against the interleukin-5 alpha receptor expressed on eosinophils, may be an option for treating EGPA. Methods: We conducted a multi-center, double-blind, Phase 3, randomized, active controlled non-inferiority trial to evaluate the efficacy and safety of Benralizumab as compared with Mepolizumab. Adults with relapsing or refractory ECA who were receiving standard care were randomly assigned in a 1-to-1 ratio to receive Benralizumab, 30 mg, or Mepolizumab, 300 mg, subcutaneously every 4 weeks for 52 weeks. The primary endpoint was remission at weeks 36 and 48, pre-specified non-inferiority margin, minus 25 percentage points. Secondary endpoints included the accrued duration of remission, time to first relapse, oral glucocorticoid use, eosinophil count, and safety. Results: a total of 140 patients underwent randomization, 70 assigned to each group. The adjusted percentage of patients with remission at weeks 36 and 48 was 59% in the Benralizumab group and 56% in the Mepolizumab group. Difference: 3 percentage points, 95% confidence interval, C, minus 13 to 18, p equals 0.73 for superiority, showing non-inferiority but not superiority of Benralizumab to Mepolizumab. The accrued duration of remission and the time to first relapse were similar in the two groups. Complete withdrawal of oral glucocorticoids during weeks 48 through 52 was achieved in 41% of the patients who received Benralizumab and 26% of those who received Mepolizumab. The mean plus or minus blood eosinophil count at baseline was 306.0 plus or minus 225.0 per microliter in the Benralizumab group and 384.9 plus or minus 563.6 per microliter in the Mepolizumab group, decreasing to 32.4 plus or minus 40.8 and 71.8 plus or minus 54.4 per microliter, respectively, at week 52. Adverse events were reported in 90% of the patients in the Benralizumab group and 96% of those in the Mepolizumab group. Serious adverse events were reported in 6% and 13%, respectively. Conclusions: Benralizumab was non-inferior to Mepolizumab for the induction of remission in patients with relapsing or refractory ECA. Microplastics and nanoplastics in atheromas and cardiovascular events. Background: Microplastics and nanoplastics, MNPs, are emerging as a potential risk factor for cardiovascular disease in preclinical studies. Direct evidence that this risk extends to humans is lacking. Methods: we conducted a prospective, multi-center, observational study involving patients who were undergoing carotid endarterectomy for asymptomatic carotid artery disease. The excised carotid plaque specimens were analyzed for the presence of MNPs with the use of pyrolysis gas chromatography mass spectrometry, stable isotope analysis, and electron microscopy. Inflammatory biomarkers were assessed with enzyme-linked immunosorbent assay and immunohistochemical assay. The primary endpoint was a composite of myocardial infarction, stroke, or death from any cause among patients who had evidence of MNPs in plaque as compared with patients with plaque that showed no evidence of MNPs. Results: a total of 304 patients were enrolled in the study, and 257 completed a mean, plus or minus, follow-up of 33.7 plus or minus 6.9 months. Polyethylene was detected in carotid artery plaque of 150 patients, 58.4%, with a mean level of 21.7 plus or minus 24. 5 g per milligram of plaque, 31 patients, 12.1%, also had measurable amounts of polyvinyl chloride, with a mean level of 5.2 plus or minus 2. 4 g per milligram of plaque. Electron microscopy revealed visible, jagged-edged foreign particles among plaque macrophages and scattered in the external debris. Radiographic examination showed that some of these particles included chlorine. Patients in whom MNPs were detected within the atheroma were at higher risk for a primary endpoint event than those in whom these substances were not detected. Hazard ratio, 4.53, 95% confidence interval, 2.00 to 10.27, p less than 0.001. Conclusions: in this study, patients with carotid artery plaque in which MNPs were detected had a higher risk of a composite of myocardial infarction, stroke, or death from any cause at 34 months of follow-up than those in whom MNPs were not detected. Omalizumab for the treatment of multiple food allergies. Background: Food allergies are common and are associated with substantial morbidity. The only approved treatment is oral immunotherapy for peanut allergy. Methods. In this trial, we assessed whether Omalizumab, a monoclonal anti-IgA antibody, would be effective and safe as monotherapy in patients with multiple food allergies. Persons 1 to 55 years of age who were allergic to peanuts and at least 2 other trial-specified foods, cashew, milk, egg, walnut, wheat, and hazelnut, were screened. Inclusion required a reaction to a food challenge of 100 mg or less of peanut protein and 300 mg or less of the 2 other foods. Participants were randomly assigned, in a 2-to-1 ratio, to receive Omalizumab or placebo administered subcutaneously, with a dose based on weight and IgA levels, every 2 to 4 weeks for 16 to 20 weeks, after which the challenges were repeated. The primary endpoint was ingestion of peanut protein in a single dose of 600 mg or more without dose-limiting symptoms. The 3 key secondary endpoints were the consumption of cashew, of milk, and of egg in single doses of at least 1,000 mg each without dose-limiting symptoms. The first 60 participants, 59 of whom were children or adolescents, who completed this first stage were enrolled in a 24-week open-label extension. Results. Of the 462 persons who were screened, 180 underwent randomization. The analysis population consisted of the 177 children and adolescents, 1 to 17 years of age. A total of 79 of the 118 participants, 67%, receiving Omalizumab met the primary endpoint criteria, as compared with 4 of the 59 participants, 7%, receiving placebo, p less than 0.001. Results for the key secondary endpoints were consistent with those of the primary endpoint: cashew, 41% versus 3%, milk, 66% versus 10%, egg, 67% versus 0%, p less than 0.001 for all comparisons. Safety endpoints did not differ between the groups, aside from more injection site reactions in the Omalizumab group. Conclusions. In persons as young as 1 year of age with multiple food allergies, Omalizumab treatment for 16 weeks was superior to placebo in increasing the reaction threshold for peanut and other common food allergens. Hi, this week in medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Enfortumab Vedotin and Pembrolizumab in untreated advanced urothelial cancer. Background. No treatment has surpassed platinum-based chemotherapy in improving overall survival in patients with previously untreated locally advanced or metastatic urothelial carcinoma. Methods. We conducted a Phase 3, global, open-label, randomized trial to compare the efficacy and safety of Enfortumab Vedotin and Pembrolizumab with the efficacy and safety of platinum-based chemotherapy in patients with previously untreated locally advanced or metastatic urothelial carcinoma. Patients were randomly assigned in a 1-to-1 ratio to receive 3-week cycles of Enfortumab Vedotin, at a dose of 1.25 mg per kilogram of body weight intravenously on days 1 and 8, and Pembrolizumab, at a dose of 200 mg intravenously on day 1, Enfortumab Vedotin Pembrolizumab group, or gemcitabine and either cisplatin or carboplatin, determined on the basis of eligibility to receive cisplatin, chemotherapy group. The primary endpoints were progression-free survival as assessed by blinded independent central review and overall survival. Results. A total of 886 patients underwent randomization, 442 to the Enfortumab Vedotin Pembrolizumab group and 444 to the chemotherapy group. As of August 8, 2023, the median duration of follow-up for survival was 17.2 months. Progression-free survival was longer in the Enfortumab Vedotin Pembrolizumab group than in the chemotherapy group, median, 12.5 months versus 6.3 months, hazard ratio for disease progression or death, 0.45, 95% confidence interval, c. 0.38 to 0.54, p less than 0.001, as was overall survival, median, 31.5 months versus 16.1 months, hazard ratio for death, 0.47, 95% c. 0.38 to 0.58, p less than 0.001. The median number of cycles was 12, range 1 to 46, in the Enfortumab Vedotin Pembrolizumab group and 6, range 1 to 6, in the chemotherapy group. Treatment-related adverse events of grade 3 or higher occurred in 55.9% of the patients in the Enfortumab Vedotin Pembrolizumab group and in 69.5% of those in the chemotherapy group. Conclusions. Treatment with Enfortumab Vedotin and Pembrolizumab resulted in significantly better outcomes than chemotherapy in patients with untreated locally advanced or metastatic urothelial carcinoma, with a safety profile consistent with that in previous reports. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.